Other medications that I think we really need to be careful about are the medications that are specific to the neurosensory, the neuro system, the neurological system. And these are, to give you an example, like I did before, are your antiepileptics, Depakote, whatever else that is. And so when you see a patient is admitted to hospice, or when you're taking care of a patient and you see that they're on an antiepileptic, that is key. You cannot interrupt, just like the pain medication too, because if you interrupt pain medication, the patient can not only experience a lot of pain, but they can experience withdrawals. And I will take a quick pause here. Other forms of medications do apply here. If your patient is getting, say, oral Dilaudid, you maybe can transition to a fentanyl patch. But, again, with fentanyl patches, you need to make sure there's substantial subcutaneous tissue. You don't want to be putting it on a patient that is cachectic, and if anything, ensure that it's put on a fleshier part of the body so that they are absorbed accordingly. But look at that pain medication and ensure that there is a way to ensure therapeutic levels in the blood and that it does not get interrupted. Other medications that are really critical here in terms of maintaining patient safety and comfort. Antiepileptic medications, and then we'll get into another form of medications as well. Antiepileptic medications are things for seizures, to prevent seizures. This is a real kind of big flag that we really want to get used to seeing and kind of, helping everyone else see when we see it. When you see a patient, or when a patient is admitted on hospice, again, we're going through that medication list. We're reviewing that entire care plan, obviously, but going through each medication and seeing what we need to ensure to do for each of those medications to ensure therapeutic effort. It's not done for every medication, obviously, but for these ones that are going to really impact the patient's comfort and safety, it's really critical. Seizure medications and antiepileptics are critical here. So if you see a patient is on medication to treat or prevent seizures, you must ensure that they are seamlessly transitioned to another form of delivery when the patient can no longer take those pills. Okay? We can kind of get that based on our story. Remember my story. So again, you can say your patient is getting Depakote. Again, you can say when the patient is no longer able to take oral medication, you can either administer the Depakote rectally. Again, the only question about giving certain medications is every medication is a little bit different, is absorbed in a different degree when given rectally. Emiscontin, Kadian, those medications are absorbed well rectally. But, for something like with, when you're talking about with seizures, something that may be a little bit more therapeutic, at least what I found when I was, working with this type of approach to care planning, was just to have Valium suppositories, because they keep that nervous system really calm, cool, and collected, or Ativan, and have the Valium suppositories for emergencies. We created a seizure comfort kit that way, which I will talk about and share what I did. So an example would be when the patient becomes unable to take oral medications /MPO, discontinue oral Depakote or oral Keppra and start routine Ativan sublingual, 1 milligram every 6 hours routinely. That can be an example. And so again, if your facility, policies, whatever, are a little bit different and you don't want that specific of an order, I would help your team out and get an order that says when patient is no longer able to take oral medications, call physician for new orders to address to transition, or to let's say, I'm having a hot flash, and so I can't think for a second while I have a hot flash. But then you'd say, call physician to obtain new orders to address the routine Depakote, therapeutic dosing, or to get new orders to discontinue the routine Depakote, or to obtain new orders for antiepileptic palliation, for example. So you'd want to get something like, say the patient's on Keppra routinely, and you have an order for, say, when patient becomes NPO or no longer able to take oral medications, call physician for new orders. And in parentheses, you can say to address antiepileptic therapy, routine antiepileptic therapy, for example. So that may make things a little bit more comfortable depending on your facility. But again, we had, in our case, we developed some comfort kits, not just a standard comfort kit, but we developed one of our many comfort kits. Few of our comfort kits was a seizure comfort kit, and we had Valium suppositories in that comfort kit. So that was great because we already had those Valium suppositories there. We could start administering them and then order more as needed. I think we only had about 3. So you're not being wasteful. You have a few there on hand, if and when you need it. You get the patient, keep that patient therapeutically managed in terms of, an antiepileptic in their bloodstream, and then you can always order more. And on top of that, so doing like a routine Ativan or routine Valium suppository is a really, really nice transition for someone who is on antiepileptic medication or antiepileptic medications. Again, your dosages are going to be specific to that patient, depending on how many and how much of antiepileptic medications they're on. So obviously, get the orders from your doctor. But you can help your doctor out and your practitioner out and your amazing nurse practitioners, who we love, nurse practitioners and PAs, to kind of guide them and say, I'm really concerned about the patient, ensuring that they have therapeutic levels. So how can we make sure there's no interruption in that therapeutic level of care? Great, cool. The other medications that are not so obvious, that I had a little bit more pushback, but once we got it down, I think we did pretty well. And these are medications that are related to, again, the nervous system, but for other types of conditions. Medications for depression, medications for anxiety, medications for types of, and I don't like to use the term behavioral issues, but types of, when patients would say act out, things like that, So, and patients, just to kind of be clear, when a patient's acting out, it's more than just them acting out. There are other things that we can do to help them manage it, and non-pharmacological things, which I will be sharing. But let's get back to it. There's just so much to share with you that I want to make sure you know. Anyway, so examples. Zoloft, Paxil for depression. What else? Depakote as well for any types of, anxiety, things like that. Gabapentin, Neurontin, all these types of things. Again, I want to be clear here. I am not saying that it's your job to figure out what the medication should be. I'm giving you what I have seen that has worked based on the orders that we have received in my past life. But this is another opportunity here, particularly when you're dealing with someone who has been on, say, an antidepressant for years, to immediately interrupt therapy and cease therapy because they're no longer able to take oral medications, and then not do anything about that and not have anything prepared is not a good way to palliate that patient and ensure their palliation, particularly when I'm talking to you, hospice personnel and palliative care personnel. We're the experts, right? So we really want to make sure that we're thinking a little bit beyond the obvious. So again, your orders are going to depend on the patient and what the practitioner orders, but sometimes, when you have these people that are on these medications, what's the real critical thing about these medications? They take days to weeks to build up therapeutic levels in the blood. And, whenever you're making changes, you do so incrementally, you do so one by one, So just to think that if you stop them abruptly, what can happen? The side effects. Side effects of Cymbalta are brain zaps. They are extremely uncomfortable. And I only remember that, know that because at one point in my life, I was on Cymbalta and I was coming off, and I guess I was coming off a little too fast, and I ended up having brain zaps. And that was terrifying because you feel your brain, it's almost like it's being electrocuted. And what can happen there? Yes, they can go into a seizure. They can go into other, anxious type of behavior. But especially if they're on these medications, gabapentin, especially not only for neurological stuff, but also for pain, you can't abruptly stop these medications just because your patient can't take the pills. So just because your can't patient take the pills doesn't mean that there's, that we just kind of, we'll give the routine, then we'll give the as needed Ativan or something, or Haldol if they need it. No. We got to have something in place. So for these medications, depending on what they have and depending on their history and all that kind of stuff, you can do things like prepare once the patient is no longer able to take oral medications, to obtain orders to discontinue those routine medications that are for the depression, for the anxiety, whatever it is, and obtain orders for routine something like, sublingual Ativan or lorazepam, sublingual Haldol, or, per rectum type of, Valium, for example. Something like that. Something to keep that nervous system calm, cool, and collected after you stop those routine medications. Again, the dosages and medications are all going to depend. And again, depending on your policy, if your facility or your entity is not comfortable with you getting a specific order for a specific medication, what are you going to do? Get an order to, when the patient becomes no longer able to take oral medications, contact physician for new orders, and you can say to address the therapeutic levels or therapeutic palliation around, anxiety or pain or depression related to these certain medications. Okay. So those are the general types of groups of medications that I have found that when we do things right and when we ensure a seamless transition of therapeutic levels, it really does keep the patient comfortable. Now, sometimes you're going to be discontinuing medications, obviously, that you're not going to continue. So you're going to be discontinuing oral medications that you're not going to try to figure out a therapeutic effect to continue. Excuse me, that was the wind. And so example of these medications typically are things like, say the patient's on a beta blocker, right? Or calcium channel blocker because they have an AFib or something like that. And that's when you need to talk to your families and help them understand, or your patients, that these, while we're working to really ensure therapeutic levels and benefits of these other medications, because these really are directly, intimately connected with symptom management, symptomology, and your comfort and the patient's comfort, there are certain medications that we won't continue. And they may go, well, why? That he's been on this beta blocker forever. Okay, but these are medications that, in terms of symptom management, things like that, we most likely won't continue or try to figure out a way to continue it in another route, because, you can't give a beta blocker in another way typically, and you won't really be giving them rectally. You can only really do that in an ICU setting intravenously. But we're looking at, of course, maintaining the patient in their home, wherever that may be, and keeping them comfortable. And, changes in heart rate, is that really going to be, an issue in terms of their discomfort? Possibly. But then if you're managing their anxiety and their other, pain and things like that, then it should be better managed. So that's just an example. What you want to do is you just want to educate your patients and families as to, the different medications that you want to ensure you have therapeutic levels for, and other ones that are simply discontinued because we're following the natural progression of the disease, right? We're not trying to correct, we're not trying to cure the congestive heart failure. But what we're trying to do is allow for the natural progression of the disease to take place, which is a very, again, gentle, very loving way to allow for disease process to go. You're not trying to interrupt and trying to cure, particularly at this stage of life where these treatments, these curative treatments, are proven to be futile, okay? So what we're trying to do, though, is treat and aggressively treat the symptomology. And that's where you're going to really excel and do a great job taking care of your patients and your loved ones. So all that said, when you are talking to your patients and families, we need to help them understand what we're doing and why we're doing it. I know that's kind of obvious, and this is where I'm going to talk a little bit more about the methodology, but try to avoid just telling them what you're going to do. Have them understand and take it in bite-sized pieces. For these families, they're already extremely overwhelmed emotionally, even if they don't appear to be. People express, and they have different affects depending on who they are and how they've expressed their feelings in the past. So even just because someone looks calm and like they're taking it in doesn't necessarily mean that they are, particularly if they're a caregiver. They could just be overwhelmed and tired, and they could be in a freeze state. So break this down into small little bits and pieces, but maybe address, like say, this medication, what we're going to be doing, what I'm doing right now is I'm getting orders from our physician because I see mom has been on something for her seizures for the last year or so. And we really want to make sure that she remains comfortable, even though she will get to a point where she can't take her pills for her seizures anymore. So what we typically do is this. So, and then what you want to do is you want to do a teach back method, which I will be getting into, but give them in little bite-sized pieces, ask them frequently throughout your discussions with them and what you're telling them, ask them frequently. I just want to make sure that that makes sense to you. Can you tell me how you understood that? Because I want to make sure that I was really clear and effective in what I was covering with you. And leave it to just the medications for that, say, visit. You can come back, or have another person come back later and talk more about oral care, whatever it may be. So I know we covered, several examples in terms of the types and groups of medications that I have, particularly my experience have run into, and I have found very helpful. The other one I failed to mention, along with kind of cardiac medications, is when you have typically people with cardiac heart failure, diastolic, systolic, they are at risk, as we know, for pulmonary edema, flash pulmonary edema, fluid overload. So in those cases, as part of my, the part of the comfort kits that I developed was to have something like IM Lasix available as part of the comfort kits, because then you could then administer the IM Lasix in, some parts, for cachectic patients, obviously not in the deltoid, maybe in the vastus lateralis or gluteus muscles, and you can give that to them. But again, what you really want to make sure is, yes, you have the orders in place, but then ensuring that the caregivers of the facility, your team, the whole hospice ET, the family members, whoever's involved in that patient care and that whole unit of care, understands that these orders are in place already to either contact the physician, or at the time when the patient can't, take the oral medications, yes, contact the physician, get new orders for whatever it is, or discontinue, get the orders all ready to discontinue the routine, whatever it is, and start, something per rectum or something sublingual routinely to maintain the palliation of that patient. So again, quick little recap. Every patient, when they are at end of life, they're going to stop being able to tolerate oral ingestion of food, of pills, whatever it may be, fluids. In this particular video, we covered oral ingestion of medications and what happens when that ceases. So what we need to ensure is that, particularly for certain medications like pain medications, antiepileptics, any type of medications that are related to, neurological comfort or conditions, and, types of maybe cardiac conditions, that we have orders in place that when the patient becomes NPO, we already have the orders in place to start, after discontinuation of those routine medications, to start something else routinely and in another form and another route of administration to ensure their comfort. So I know that was kind of a little bit of a longer video, but let me know if you have comments or questions. And by all means, if there are a group of medications that I missed, or that you're like, hey, well, I actually tried something different, or like, Abigail, what about this? Please put them in the comments, and I will ensure to either address them in the comments directly, or, if certainly I'm sure it could be really helpful to everybody else, I will ensure to do another video, because this is such a key thing, and I have seen it work and seen it implemented. And once it was implemented, and it was just amazing to see that the patient was able to remain comfortable and not have a grand mal seizure, not have anxiety at end of life, because they were just, their care was just seamless, despite the changes in the decline of the patient that occurred. So really, really key, because remember, we only have one chance to do this thing right, to die better. And we certainly want to make sure we die better. So let's continue to ensure we all die better at end of life. Let's continue these conversations and education around death and dying. And I will see you in the next videos. Take good care, everybody.